Jason wins the prize also for the largest PowerPoint presentation, but I've seen the end result and it's definitely worth it. So, Jason, welcome.
Get the perspective of the volunteers.
People who are having the worst day of their lives.
Who give up their free time.
One call you really don't want to get came through.
To buy patience.
He's smelling the blood.
More time.
It's all about managing chaos.
The hardest jobs that we do are those jobs involving critically ill children.
This is not good. This guy's dying.
Seconds to Live. Thursday at 10 on RTE2.
Roger that.
So, gratuitous voyeurism, or is this a serious, concerted, and quite deliberate attempt to shine a positive light on our specialty? You can decide, I don't mind. Look, Seconds to Live and emotive kind of titles like that. End of the day, if we put it in a cardiac arrest situation, little Tom Garney there, son of two of our GP colleagues in Kerry, he went down on the GAA pitch. And Seconds to Live for him was hard and fast in the chest, hard and fast in the chest. It's that Vinnie Jones thing. None of this kissing nonsense, hard and fast in the chest. Keep going. But that's the point, all right? We need to change how we're thinking about things. The call comes into ambulance control. Now what we have is the controller takes the call and talks through what? Hard and fast in the chest, okay? Hard and fast in the chest, and three things happening simultaneously. So, as that call comes in, there's 2 ambulance resources dispatched. And that ensures there's enough hands in the scene to ensure that hard and fast in the chest continues and that evidence-based care gets started, the start of one of your clinical care pathways. Simultaneously, a text alert goes out to the local cardiac first response group. Unfortunately, that was the guy because he went down in the GAA pitch. And where does the defibrillator come from? There, not the first hard and fast in the chest. And simultaneously, we have a new system where text alerts go out to National Ambulance Service assets. And those assets can be Gardaí, it can be fire. Certainly in Cork, we've got a very good relationship with the fire service. It could be one of our critical care support units or physicians based in Cork or Wicklow or Mayo, but that's what I'm here to talk about.
And the checkered flag. So into the pit lane he comes. Something around a 15
I probably put the wrong video in there. Anyway, the McLaren boys are pretty good. I mean, 2.31 seconds. 2.31 seconds to take on 150 litres of fuel and change forced tyres. 2.31 seconds, that's pretty awesome. And this is human factors in play. So human factors in play in healthcare in cardiac arrest. So when the paramedics arrived at Tom's side on the GA pitch and carry on hard and fast in the chest, there's actually a plan going ahead. There's a whole planned process. It's not just about getting some external fancy piece of kit on, but we use those anyway. But it's about how we work as a team. And to do that, they actually bring out a checklist. So it seems quite daft. You pull out a checklist, say, right, are we doing this? Check. You do this. Check. You do that. Check. And keep it going. It's about how you integrate all those different agencies and different types of people arriving by Tom's side. He's 16 years old. He's on the GA pitch. It's emotive. It's about taking control. It's about providing a clinical environment in a non-clinical area. This checklist lays out where all the kit goes. We've started not putting IV access in, but we go for IO access because we know it's faster and it's reliable. We're not wasting time. Because IV drugs, well, they're evidence-based, it's not what they need. Okay, and the same with going then for supraglottal devices, for example, because they're saving time. It's not about putting that tube down and potentially destroying an airway in a perfectly good, healthy 16-year-old. But I'll come back to that case anyway. Ambulance drivers. Now, I guarantee you that if you use that term out of this room, you'll be lynched, okay? Ambulance drivers is what we had 20 years ago. And I've seen an amazing transformation, even the short period of time that I've been in Ireland in the last 10 years. These guys are true professionals. And working with them day in, day out, I can honestly say, hand on my heart here, I don't want any of yous treating me pre-hospital when I have an MI or my traumatic brain injury. All right? Any of yous. Unless you're trained in working in that environment. Because it's not about the medical care necessarily, it's how we work in that environment. It's the same reason why you don't necessarily want an insert any ologist that you've lately been pissed off by here coming down and telling you how to work in the emergency department. So, you get ROSC. Now, this wasn't Tom's case, this was another case. You get the guy back, and now we've got to get him somewhere. And of course, the evidence shows if we use all the state's assets wisely, so here's us in West Cork, we certainly use a lot of the Irish Coast Guard to transport us places. This is their faster ambulance. Okay, we get then to where we need to go. And where we need to go is a center of excellence. So if you're doing your trauma pathways, it's some sort of level 1 trauma center. Of course, if we did that every time, everybody would be arriving in Cork, but I mean, we'll let Dublin sort itself out. Okay, but I mean, this is working because Galway, 1/3 of all of the STEMI cases now arriving and successfully wire-crossed in Galway come by air ambulance. And most of the time, it's not the National Ambulance Service, it's via the Coast Guard. So we're integrating our pathways quite well. It's starting to work, folks. It's getting better. It's getting better and better and better. Supporting the structure, I assured Jerry I wouldn't talk too much about Cork, but I have to talk about my own department. I'm clinical lead nationally for emergency telemedicine. We run the HSC's emergency telemedical support unit. So I look after maritime users, Coast Guard, all the Irish merchant fleets. But we also have developed over the last few years in looking after the National Ambulance Service and our military. I'm very proud of the military one. We've been supporting the guys in the Med. But the National Ambulance Service and Dublin Fire Brigade certainly account for the majority of the work we do. And it's a seamless interagency thing. Nationally, we've one port of call, and so we can audit and govern and look at the advice we go and go, hang on, that was a bit pants, and we need to change that way of doing things. And we keep it nicely, tightly controlled, okay? Because your pathways want to be neat and tidy. We've looked at wonderful pathways this morning, and it's all on paper, and it works in your own head. But what happens when you try and implement it on the ground? That's when things can go a little bit awry, when people maybe don't agree or whatever. But these pathways all are one, they're time critical, aren't they? No shit, Sherlock. Okay? And if you are septic, when do you want your antibiotics? Let me make it more emotive. When your child is septic, when do you want your child's antibiotics to start? Well, you don't want unnecessarily tazocin given to the whole world like we're currently doing at the moment, do we? We need to have some evidence and some rollbacks and some quality clinical evidence and clinical controls. And so, for example, just out of interest, we're about to launch a trial on the National Ambulance Service with lactate measurement pre-hospital. So we can be definitive about it, and then we can give proper antibiotics early. So we can do all the service criteria, exactly what we do in the emergency department, but pre-hospital, okay? So there's another one there, STEMI care one is obvious. The trauma care one, well, we'll need to come back to that. But I'll ask you the question, when do you want your child, God forbid, they have a traumatic brain injury, neuroprotective anesthesia to start? Do you want it to start in the hospital when they arrive? Or do you want to start as soon as after injury? I mean, it doesn't make sense, okay? Now, there's a lot of talk about that place north of Cork, and they're going to get their HEM service thanks to our dearly departed friend, John Hines. We had 6 of us pre-hospital emergency medicine and critical retrieval guys in Ireland. We're now down to 5, but we will swell our numbers again. And John's dream is it will be reality in the north. But let's talk about Cork, because I'm quite proud of Cork. And the best way to start is here.
My father, who was working in East Cork as a GP, responded to a need, I guess, and developed his own pre-hospital emergency service. And that included providing immediate care at the roadside and in the home. I was infected by that bug.
So at East Cork Rapid Response, if you want the Twitter handle for that, the service provided in 1975 by Hugh's father, if you recall back then, it was GPs providing emergency medicine essentially. Okay? And things have progressed along there. So let's progress. Let's keep going. But before we do that, I'm going to talk about stovepiping. Now, I haven't spelt that incorrectly. That is how we spell stovepiping in this context. Just a slight nod if somebody actually knows what I'm on about in healthcare. I bet your managers will start to pick this one up. Stovepiping. Okay, in South Africa, we used to talk about this when your Glock used to misfire and it looks like a bit of like a stovepipe sitting there. And you had to recock it and throw out the discarded cartridge before taking them out? No? All right. Okay, that's the one I understood. But actually, in the healthcare service, by the way, South Africa, okay, if it comes into your head now, what is the number one killer? Sorry? Okay, it's not trauma. Okay, it's trauma sits there. But in terms of disease, take trauma out of it. What's the number one killer? Sepsis. Okay. As people have heard HIV/AIDS thrown about in here, because whenever we produce African and sub-Saharan African data, it's HIV/AIDS. That's stovepiping. Okay? Because actually it's not HIV/AIDS. The number one killer in South Africa at the moment is TB. Okay? But money is not going to get pumped into TB. So very cleverly, if you want money to be pumped into HIV/AIDS, you say that he's died of TB. Has he got HIV/AIDS? Yeah. Okay, he's died of HIV/AIDS. And that's what goes down. That's called stovepiping. Okay, and it's about just selling something in a different way. What are we in emergency medicine very bad at doing? We're very bad at politics. We're very bad at selling ourselves. Okay? So we don't get stovepiped into any of the funds. And you've got these creaky, cracky silos. And we know about silos. If you talk about silos in healthcare, that's talking about different ologists and different specialties. And everybody's fighting for the same crumbs, aren't they? So if you say you can do something, all right, and it starts to creak and crack a little bit because actually you're not delivering the service you're providing, what happens? It all splits apart, doesn't it? Okay? And who picks up the crumbs? All right? And everything else doesn't function as well because it doesn't safely function as well. So we actually got to be honest about the care that we can deliver and the care that we can provide. And we've got to be honest within these contexts of silos. And if I talk about silos, my background is anesthesia and intensive care medicine. I worked pre-hospital in Cheshire in the UK. I could have fallen off the end of the thing there and taken up a consultant job, but no problem, okay? And I came to Ireland because I love Ireland, I love the family life, and, you know, it's a far better place to live. Cliff, next, you can come back here if you want, right? All right? But when I came here and I joined the anesthetics intensive care community, I soon realized one thing: silos. And I couldn't function in the job that I was trained to do because of silos. I couldn't provide critical care, pre-hospital critical care and retrieval medicine. Silos, okay? And those silos need to go. And before I now launch and dive into what I really want to dive into, it's not all about pre-hospital critical care. It's not all about the critical care thing, because that's only a tiny little thing that we're doing. We've heard about from the AMP program about the minors. Okay, that is our 75%. The majors and the surgical admissions, actually, those are ologists' patients. I love the critical care side of things, but I have to acknowledge this. When Prof. Kuzak did this study, when we put a doctor on the response car on a Thursday in Cork City, emergency medicine discharged 31% of those ambulance calls at scene. They weren't transported. If we had a pre-hospital emergency medicine physician 24/7 in Cork City over December, we would have prevented 500 hospital admissions. Just putting it there. It's not all about the fancy stuff. It's about the sensible stuff. This is the stuff I like that. Look, it's not all about being adaptive, and it's not all about taking that hospital medicine pre-hospital. It's about providing a safe clinical environment in a non-clinical area. And with an anesthetic hat on, whenever I used to come down to the emergency department, I used to see a non-clinical environment, an unsafe environment. I wanted to get that patient back to ICU, or I wanted to get that patient back into my comfort zone, which was maybe an anesthetic room or something like that, or operating theater. All right? And over time, I'm very proud to say, mostly with nursing support and CUH, we've actually managed to turn that around. And our anesthetists are now coming down, realizing that our resus bays are very well stocked, safe, human resource positive, critical care areas to work in. Okay? And we can make a huge difference in that. The only difference we do is we put that out on the side of the road. So, pre-hospital emergency medicine and critical care retrieval is a reality in a number of places. So I'm going to take that Tom's case back again. Now, Tom is now, the AP is sitting with Tom. He's got ROSC. But little Tom, he's age 16. He's now combative. He's obtunded. He's hypoxic. He's got pulmonary edema. He is circling the drain. And they are sitting in rural Kerry. Two choices: 30 minutes to Tralee General Hospital or an hour and 20 minutes to Cork? Where's cardiology? It's Cork. What do you do as an AP? You rightly go 30 minutes to Tralee, don't you? Okay, for stabilization. The difference is they have the opportunity to call, ask the ambulance service, is one of the doctors available? Okay, so what we do is we meet them. So I rendezvoused on the Cork-Kerry border. They don't allow me across because I'm from West Cork, and I don't have a passport for Kerry, but under special arrangements, I could sometimes cross the border. But anyway, Ballivilla, we met them out there on the Cork-Kerry border, provided that same critical care they would have received at Tralee General, and then did a primary critical care retrieval back to Cork on inotropes, on ventilator, et cetera, et cetera, et cetera. Okay, and I mean, Tom has obviously done it very, very well because you saw a picture there with his dad, and he's got onto RT and trying to promote this, okay? And now, it's not just Cork. There's Jason Horan, emergency medicine consultant in Mayo. That's him just doing a critical care retrieval from the side of the road to Galway following a road traffic collision. And David will hate me for that photograph, but David's going to obviously talk to you about the critical care retrieval programs, transfer medicine programs. I'm only offering an emergency medicine solution to a national Irish problem, okay? We work in a very well-governed, structured system with extremely good telemedical support, okay? So through the telemedicine service, I can access any of our colleagues in emergency medicine, all right, at any hospital, talk directly to them, and make sensible decisions, all right? It's not difficult. So this is a 4-year-old after being driven over by a car and badly burnt as the car was resting on him, okay? He's fine, he's asleep, or he's back at home, he's perfect, all right? It's not about faster ambulances. Because the old way of working is get the patient to hospital quickly for their definitive care, isn't it? Okay? You can provide that start of that the life-saving care, definitive care, pre-hospital, and it's not rocket science. Okay? When you see it, you can laugh. Okay? It's no shit Sherlock. Okay? If you put a clinician in an aircraft, we can solve our critical care retrieval problems tomorrow, overnight. It's not difficult. And not just locally in Wicklow or Galway or Cork, but around the country, like my friend Sinead's little daughter here, who swims with my boys. You know, when they have their really serious head injury, we prevent that secondary brain injury. Okay? Here's a boring slide. Cliff might recognize it. It's an extremely boring slide, but let me say what happens when we talk together, break down those silos, work together, and integrate a trauma system. Okay? Now, that's a logarithmic scale. So when you put it into real terms, what happened in England and Wales in 2012 when they introduced the trauma systems, from then to 2015, you got a 50% increase in survival rate from major trauma. That's the sort of things we can do when we work together. Work out those human factors things. It's actually not about the care we provide, it's how we work together and how we integrate. Okay? And yet, we've got problems with language in Ireland, don't we? So what is the HSE definition of trauma? So it's a 145-page document telling us about what trauma is. What is it? It's when the bones aren't straight. What is the HSC's official line on polytrauma? Well, it's 2.5 pages in a 145-page document. It's when the bones aren't straight and something's got in the way of straightening the bones. Okay? So it's another ologist has to get involved. And it's language, people. Is emergency medicine in crisis, in your opinion? Hands up. Okay, who's too scared to put their hands up? Is emergency medicine in crisis? Yes? Okay. I don't think so. I think we're scapegoated, and I think our image is in crisis. We're not in crisis. We're perceived incredibly badly in the media because we're allowed to be perceived incredibly badly in the media, because we don't have a voice. We're not talking up. We're not boasting about our achievements. All right, I'm happy to say what we do in Cork. We save lives. And you guys do it all around the country, and you do it incredibly well. We are the specialists that specialize in flow. We don't need external people to come and tell us how to make flow work in our departments. We do it day in, day out. We provide safe care. And I'll show you how good emergency medicine is. But it's all about flow.
The
all about flow.
Unmistakable feeling of unstoppable. Of no problem that can't be solved. Of no one else can do it better. That whatever the day throws at you, you simply take it in your stride. Because you've found your rhythm. You're on top.
Tell me your day hasn't felt like that. We're good, we're good, we're good. This is Ferdia, he's 6 weeks old. Period of bradycardia, CPR for about 1 cycle, literally just a minute, picked him up again. We're the world's experts at flow, we manage chaos every day, okay? And maybe we should be talking about brand emergency medicine, because brand emergency medicine is incredibly powerful. 1.2 million people flock to the emergency departments. They come to us when they're hurt, sick, and vulnerable. Okay, they come to us when they're hurt, they think they're hurt, sick, and vulnerable, and we tell them to go home. But we are that beacon. We are that safety net. We are so good at what we do, the GPs send patients to us to solve the problems that they can't solve themselves. Okay? We are so good at what we do, that we're the only people, our nurses are the only nurses in the hospital that can care for patients on trolleys. Is that because we're so good at what we do? Yes, it is. Okay, we've created these safe systems, all right? And we're so good at what we do that we discharge 900,000 of those patients a year. That is 76% of patients who turn up in the emergency department are discharged by emergency medicine treatment complete, all right? I thought we were in crisis. We're not in crisis. We're the most efficient specialty in the HSE. We've been forced into doing it. We've become that. And that's unbelievable odds to get to that stage. So why are we allowing ourselves to be rogered by the media? Why are we allowing ourselves to be rogered by other specialists? Why? All these patients that are falling through the cracks because of the silos, we're the ones that are picking them up. We're the ones that are sorting them out. We're the ones that are coming up with safety net plans and getting them out there. The GPs are no longer the gatekeepers. The GPs are the coordinators. I put it to you that we're the gatekeepers now. I love this slide. It's from Eva's. Eva gave it to me yesterday. Patients attend to the ED with a GP referral in the NHS versus the HSE. Some people quaking. 5.8% versus a whole range of things around the country to where you are. And if you look at who gets admitted by the GPs when they come in, 48% of GP referrals get admitted in the NHS and 24% here. Okay? And there's a lot of reasons for that. And of course, the main reason probably is that there's nowhere else to go. We are this lighthouse. Brand emergency medicine. We are this beacon. And that's the things we've got to solve, not emergency medicine, because we do that well. Those patients aren't outpatients. Those patients are in-hospital patients. 66,000 in CUH, 47,000 out. And of those patients, and this is the frightening thing, we get slammed for what we're doing, yet our PET times, whatever KPI they throw at us, we seem to keep achieving them. All right? Those are our patients seen within 6 hours of discharge. Most of them are. Okay? And if you look at our inpatients, so this is what emergency medicine is managing in our CDUs, if you look at our inpatients, we talk about length of stay in terms of hours. We don't talk about length of stay in terms of days. We're incredibly efficient at turning people around. We've been forced to. Okay? And what about those patients on our trolleys, in our corridors? Well, they're all admitted patients, waiting beds or waiting transport home. 16% of all inpatients at CUH currently are managed by 5.5 consultants, emergency medicine. 1 CNM for CDU and 1.5 staff nurses. 16% of all inpatients at CUH right now. That's a frightening statistic, isn't it? Is emergency medicine in crisis, or are we extremely efficient? Just imagine what we can achieve if we have our space back and we're funded appropriately. I'll leave you to think about that, because we're the ones that are managing the chaos, working the chaos. We're not in crisis, we're managing that crisis, and we're managing it incredibly well. And I'll leave you with this from the Irish Times on Monday. This poor lady spent 35 hours in our corridor. She was anxious, her anxiety was rising, awful work environment, cramped conditions. Yet, what did she have to say? She was impressed. She was deeply moved. Extraordinary levels of care. She was touched. She felt respected. She was gently cajoled and humoured. Care, sensitive listening. She developed a good relationship. She was grateful. But most important, she acknowledged the heroism of the staff every day in, day out in our emergency department. We are heroic people. We just not, why do we feel we're not allowed to say that? Why aren't we retorting the press? Emergency medicine is the solution to the crisis. Emergency medicine isn't the problem. We need to look past the old ways of working, maybe to some more family-friendly models, perhaps, acknowledging the designs we're in. But emergency medicine is the solution. We're not part of the crisis. I'll leave you there.
Previously, the service operated through a number of control and dispatch centres.
Your male is unconscious, is not breathing.
The care of those who were injured was able to begin at the side of the road, and I witnessed that myself last night, rather than having them wait until they came to hospital. And undoubtedly, that saved lives.
We moved 11 of the patients to Kerry General Hospital, but we were able to fly 4 additional patients directly from the scene to Cork University Hospital, and from a hospital perspective, that spreads the load as well.
The ceremony to mark the 3 years of the emergency air medical service being here, and we've also lifted 1,000 patients in that time.
We go to other various types of incidents, then right from farm accidents to car crashes.
Now, sir, relax your leg. You're just going to have a sharp scratch in your right arm. Okay?
Bougie, yeah. Okay. I'm in.
Okay. Forceps out. Nice tube on, Bougie.
I have the tube.
Okay, I have the Bougie.
Okay, tube in.
Okay, Bougie out.
Plates cooked.
Do you want to have a listen there and see if we get a CO2 trace?
The Emergency Department Task Force held its 4th meeting today to discuss the overcrowding crisis.
We need to face up to the problem that we do not have enough capacity in the system, either beds, staff, or money, to do what the government wants done.
Well, it's a worst month for trolleys since we started counting. 9,650 people were on trolleys during the month of February.
The HSE and the Minister has the solution to this in his own hands. This isn't something that the solution isn't obvious for, but they need to sort out the delayed discharge problem for once and for all and keep on top of it every week, of every month, of every year. We need to look at this from the perspective of an individual patient. And for them, it is safer for them to be one of 1 or 2 additional patients on the ward than to be warehoused in the emergency department. We know that. The medical evidence supports that.
Great, thank you very much, Jason. That's great. I think we're running just a little over, so we might leave questions until the end. Plus, I think if we start them again, we might not be able to stop them. So.